We have everyone in here. Welcome to our media briefing today. We are going to be talking about some very interesting research that is happening in Oregon's psilocybin therapy program. I just want to let everyone know the rules of the road today. We have 4 speakers, including 2 of our researchers, and we will be taking questions at the end. If you do have a question that comes up during someone's presentation, please drop it in the chat and we will get to it at the end of our presentation today. With that, I'm going to kick it over to Heidi Pendergast from Healing Advocacy Fund.
Hi, everyone. Thank you so much for joining us today. Today, we're going to be talking with the researchers of the first ever psilocybin clinical trial of low-income individuals ever in psychedelic research, but also the first clinical trial in Oregon's state-regulated program. This will be the first in a series of research updates. Half will be putting out for media, and we'll be doing multiple ones through the end of the year in partnership with the researchers who are releasing new research in the coming months. Next slide. So as Leslie said, I'm Heidi Pendergast. I'm the Oregon Director of the Healing Advocacy Fund. Today, I'm going to provide you with a brief overview of Oregon's program to date. I'll hand it off to Nathan Howard, who's the founding board member and executive director of the Cherie Eckert Foundation, one of the main backers of this research, and they're doing incredible work to increase access in the program. We'll then be joined by both Dr. Matthew and Olivia Hicks, who led this research, and they'll really dive into the details. Next slide. The Healing Advocacy Fund is a 501c3 nonprofit organization, and we expand and protect affordable state-regulated access to all people who stand to benefit from this. Next slide. Where we work. So we were founded just after Measure 109 passed in 2020. We were founded in 2021, and we're originally just based in Oregon. With the passage of Prop 122, now the Natural Medicines Act, we're operating in Colorado. And more recently, we have expanded to New Mexico, which for the first time passed psilocybin therapy through their legislature with Senate Bill 219. Next slide. So why psychedelics? Sorry, this should be in 2025. Every single one of us on this call knows someone or they themselves have struggled with mental health issues or substance use issues. These stats highlight that. Oregon is no exception to this. There's a dire and urgent need to look at different modalities that are backed by science to help people heal. Next slide. That's exactly what this program is. It stands on the shoulders of research from across the country. This is only a handful full of the research that's been done to date and is continuing to expand. And now Oregon's program is contributing to this research, which we'll hear about today and moving forward of the impact of psilocybin therapy. Next slide. So just as a reminder of Oregon's program, it's a 3-step model. It includes preparation, and this where there's extensive paperwork, intake screening to make sure that the client is matched with the appropriate facilitator, and to really figure out what the client's goals are, and to develop an individual safety and transportation plan with the client. The next step is administration. This program happens at a licensed psilocybin center. Service centers. So the psilocybin is consumed on site. You must be 21 years of age or older in order to participate. And a facilitator who has been trained and licensed by the state will support you through your session, and you'll stay on site until your journey is complete. The last step in the process is integration. And this is really the meaning making and gleaning the from the administration session. And this 3-step process for most facilitators takes anywhere from 12 to 15 hours. So this really is an extensive process that has been laid out by the state. And I would say most of the facilitators and service centers go above and beyond the OHA baseline that has been set. Next slide. Oregon by the numbers. So there's currently 24 licensed service centers across the state. There's over 360 licensed and trained facilitators, and the program has seen over 12,000 clients since the first center opened its doors in May of 2023. Next slide. The research opportunity in Oregon is incredibly unique. It is the first time psilocybin therapy is being studied in a state-regulated real-world model. So what does that mean and what are the benefits to this? Next slide. Researchers from all across the country are studying this program and seeing significant cost savings of running a real-world study versus, say, a traditional clinical trial. Also, the scale of what's happening here in Oregon is unprecedented. There have been 5 times the number of clients through Oregon's program than all psilocybin clinical trials combined. Historically, people who wanted to access psilocybin therapy had to go overseas to other places where it was above ground. Many people who struggle with mental health issues have tried a range of costly treatments that can span years or decades. And while there is an upfront investment for psilocybin therapy, many clients report breakthroughs not seen in years of other mental health work. Ultimately, this ongoing research will help provide the path to integrate psilocybin therapy into Oregon's existing systems of care so that those who stand to benefit will seamlessly be able to access it with the support of their healthcare system and support structure. So next, I'd like to introduce Nate Howard. Again, he's the founding board member and executive director of the Cherie Eckert Foundation, one of the main funders and backers of this research. And the Cherie Eckert Foundation is a leader in the psychedelic community to increase access and support the rollout of this program. Nate, I'm going to hand it over to you.
Yeah, thanks, Heidi. Great to be here. Good to see you all. Thanks everybody for joining another Zoom, and chatting with us. So yeah, I'm going to share a little bit about our organization, the work that Oregon is pioneering, and yeah, centering these research results, which I think are a preview of what's to come, and is already arriving for people around the United States, as we are understanding this can be a very powerful form of healthcare, psychedelic healthcare. So I've got some brief remarks paired to the next slide. I don't think the next slide is really necessary, but there you go. So I can't really find anybody who disagrees with me yet, at least in a convincing fashion, that what Oregon started really in 2020 with this ballot measure, I contend that it is the brightest spot in a very bright spot, I think, in the United States, which is the psychedelic renaissance. It is a movement of understanding and working with these medicines to get at the frequently at the core of issues that drive hard to treat diagnoses or aspects of life, treatment-resistant depression, like we're talking about today, and a whole host of other things. It is an issue that remains very bipartisan and interested, from Medicaid directors at the state level to advocates who want to increase health outcomes, all the way to the highest levels of government. And so that's this is our core belief, and we see it unfolding. I invite anybody who disagrees with me, who may see this, to chat with me. I'd love to hear hear why anybody may disagree, but it is very powerful, and it's the proof is in the results, as we'll see later. So I have the honor of I think it's my favorite job today, being the executive director of the Cherie Eckert Foundation. We exist to fulfill the vision of my late friend Cherie. She was the co-architect of Oregon's state-regulated psychedelic healthcare model, which is now been replicated in Colorado and New Mexico. Now there's around 12 million Americans who live in states who now have legal access to this form of medicine. And it was first approved in 2020 by just under 1.5 million Oregonians. And about a month after we passed that baby, and Tom and Cherie, who did not have kids, referenced this project as a baby, having worked on it, as volunteers for a half decade prior. About a month after, she unexpectedly passed away. Her heart had stopped in her sleep, and she had struggled with health issues since she was young, but it was not expected. And working with Tom and some other folks in Oregon, in the United States. We built our nonprofit in her honor based off of her words and what she had written about, which is a vision around healing with these medicines while centering the problem of access. At the advent of cognitive behavioral therapy or acupuncture, there was a endemic problem of access, and eventually we made our way to understanding that it helps people, and now it's covered by insurance. And so that's part of what we as an organization exist to build towards. In the meantime, our programming is creating access now and serving as a sort of a research incubator. And so what is our mission? It is to increase equitable access in the growing and accelerating state-regulated psychedelic healthcare movement. All right, I'm almost done. Next slide, please. So since 2021, when we were approved, we've distributed or earmarked, meaning funds secured and ready to go out the door in the coming months, just over $1 million in scholarships and financial aid and funds to help spur on research. So that's a couple hundred people who've received full psychedelic therapy sessions from preparation to the journey to integration. And the focus has continued to be on folks who cannot otherwise afford this form of healthcare. And so, as I noted, acting as an incubator of sorts for real-world research, which Oregon would now contend leads the world in. We've backed 5 first-of-their-kind studies. The big one is the one we'll hear from soon once I'm done talking. And then we've also done some stuff like worked with the Healing Advocacy Fund to allocate $300,000 to what became the first cohort of licensed facilitators in Oregon, with a focus on folks who are great practitioners, come from backgrounds that are diverse as Oregon is, but otherwise could not have afforded training. So having done that and now focusing on access and research, we're also kind of tuning to what Shri talked about, which is around community building and education. So with some of the team here, we've also co-produced 2 of the revered and national Horizons Northwest conferences that have taken place at the Portland Art Museum, bringing together a couple thousand people from around Oregon, the United States, and the world to focus on what is this burgeoning economic cluster that Oregon has created and is taken over state by state because it works. So next slide, please. So as this we see, and we'll hear from the researchers momentarily, this can get at the core of issues in a healthcare system that the vast majority focuses on palliative or symptoms. It's different to get at the roots of what drives these harder to treat complex conditions. That's what psychedelics can do for folks, and that's why it is helpful frequently, at least if we listen to the last 55 years of research, for a variety of things at very effective levels, whether it's depression or PTSD, addiction, complex trauma. And yes, the promise of this is why this has been the most rewarding work of my life yet. And now we have my home state. I feel a lot of pride in it because we are now the kind of global test kitchen for real world research and healthcare. And we have a state regulated framework now that's different from the FDA, allows research to be conducted potentially for less, as we'll hear today, far less and far faster than the multi-year, multi-million, if not multi-$100 million FDA pathway. But also, we prioritize this in this model state-based culture and cultural fits. And so I'm very bullish on this pathway for folks to work with this medicine. And yeah, I'll note that the study, which we'll hear from in a moment, is the first to come, as Heidi noted. There's some very exciting additional results. And this is why we are putting a shingle out there and noting that we believe that in a very significant way, 2030, or by 2030, we will see healthcare insurance reimbursements for this type of healthcare because it is can be extremely effective and certainly much more effective than most treatments currently available. So as a dozen or so states are now working to adopt the state regulated model, we believe this type of research will start to, it can't be ignored for healthcare insurance companies that want to save money or make more money, or states that want to be better stewards of taxpayer dollars as they're considering whether or not to cover this, like they begin to cover, different other types of therapies. So, all right. I'll just note, I think that Cherie, like me, was very excitable, and had a lot of optimism. And I think that if she's seeing this, hearing this, I don't know what happens after we pass away. But I hope that she's stoked because her legacy is alive and growing, and really appreciating everybody who's here, including all of our storytellers in the form of journalists that are tuning in to share this. So, alrighty, I'm done. Thanks, Heidi.
Thanks, Nate. Now I'd like to introduce Dr. Matthew and Olivia Hicks. Dr. Matthew Hicks is the lead researcher out of Oregon Health and Sciences University and the National University of Natural Medicine. He's the founder of Synaptic Institute, a nonprofit clinic specializing in psychedelic-assisted therapy and integrative mental health care, and a licensed psilocybin facilitator. He'll be joined by Dr. Olivia Hicks, who's a naturopathic physician and licensed psilocybin facilitator based in Oregon. She is the executive director of the Synaptic Institute. Dr. Olivia Hicks served as a facilitator for this groundbreaking psilocybin therapy study, bringing her expertise and experience in psychedelic therapy to the design and delivery of the group protocol. Matthew and Olivia, over to you.
All right, thanks everybody for being here. I'm really excited to share this research with you all. So Heidi and Nate did a great job giving you some context of where this project came from. And for anyone who's paid attention to psychedelics in the last couple decades, you know there's been a lot of research that has demonstrated how these therapies can be really effective. So it's really accurate, I think, to call the period we're in a psychedelic renaissance. As you can see here, just on this little graph, how many peer-reviewed publications are coming out now on psychedelics. So that's really exciting. But one of the problems it has faced is certainly legal access, and that's been a huge barrier. And Oregon has been pioneering in creating the first legal access program to it. But it didn't solve for one of the other problems is, okay, we have legal access now, but these therapies are really expensive. They're really expensive to research, but even with legal access, they're really expensive to participate in. And even in the research we have, the very few studies that even collected income data from the participants skewed heavily toward upper income earners. And no study at all in this whole psychedelic sphere had ever done any research focusing on a low income population. So that was what I really wanted to focus on. And the crux of the issue is not the drugs themselves, because in this case we're talking about a fungus that is not patentable. And so the drugs themselves, the mushrooms themselves in this case, are not terribly expensive. The real issue is with the care that they receive from other human beings who have to provide supervision and services. And of course, when you regulate anything, regulation comes with a cost, and Oregon's model does end up being quite expensive for reasons I won't go into a ton of detail about, but just want to give you an idea of how expensive some of these licenses are. Even just a facilitator license is more than 4 times more expensive than my physician's license in the state of Oregon. And so those costs obviously trickle down to the end user, making these things somewhat inaccessible. So how did this research project come about? Was I'm a funded researcher through Oregon Health Science University, although I work more with collaborators at the National University of Natural Medicine, which I'm a graduate of, and do a lot of this work through Synaptic Institute. But I had designed and come up with this project prior to having funding for it. But around the same time, I got IRB, or Institutional Review Board, approval to run this study, was about the same time that the Sherry Eckert Foundation announced that they had their psilocybin access fund, which was a scholarship to help people access this incredible therapy who couldn't otherwise afford it. So I reached out to Nate Howard, who I'd known for years, and said, "Hey, we're trying to do similar things here. Maybe we can work together." And they were gracious enough to give us a sliver of the funding they had to run this pilot program. And then we still, because of kind of complicated rules around nonprofit status, we couldn't pay for the mushrooms. And so they were generously donated by Satori Farms, which is a licensed manufacturer or grower of the psilocybin mushrooms here in Oregon. So really grateful for all the team and the collaborators that made this happen, including Olivia, who you'll hear from in a moment, who it was a great privilege to do this work with my wife, who's a really amazing facilitator in her own right, but also my mentors and collaborators at INUNM, including Heather Zwicky and Ryan Bradley, and the staff at Chariot, which was the service center that we were able to do the study at. Okay, so let's get into the study a little bit and talk about who was in it. So the criteria that we had for the population we really wanted to serve here was those facing major depression disorder. So they were diagnosed with that. And then we wanted to look at people who were Medicaid eligible. And so that's the 200% or below the federal poverty level criteria there. But we also wanted to make sure we were helping people that we can help, which is not everybody who is low income. So we had some of these other inclusion criteria, including people having some stable housing and were engaged in psychotherapy to make sure they could actually benefit from the therapy. And of course, there's some exclusion criteria. Most of these are part of the rules in the Oregon Psilocybin Services program anyway. So we, put our marketing efforts, out there, and ended up with, we had 24 positions available in the study to serve 24 people, and we had some people who, after they were enrolled, declined to actually start treatment. But we started with 20 people who received at least the first treatment, and then we just had one person drop out at the end of it. So we had 19 people complete. So that's a really good retention rate that we're very happy with. And here's just a look at some of the demographics. It was unfortunately skewed toward white individuals. We had hoped for a little bit more diversity and struggled with that. But still pretty gender balanced. We had some non-gender conforming individuals in there, and a good range of different age groups. All right, so here's the intervention, the kind of protocol that we followed. One of the things we wanted to do was make this as much as we could, with some of our limitations, accessible to people throughout Oregon. We had to do the actual psilocybin sessions at our service center in Portland, so that's not necessarily going to get people from all over the state, but by doing some of our visits as much as we could online, we actually were able to recruit some people from Eugene and the coast and Bend, and people were able to come from a little bit farther because they only had to show up in person for the psilocybin sessions and the screening visit itself. So we did 2 preparation sessions that were both done online, and the 2 integration or like follow-up kind of psychotherapy-like sessions were also done online after those psilocybin sessions. Those are about 90-minute each. And aside from the screening visit and the 3-month follow-up, which we did one-on-one with those individuals, everything else was done in a group within the cohort. So the same 3 to 6 participants stay together throughout their whole series. And so here's another way of looking at that. It's basically a 4-week period that their involvement, primary involvement in the intervention phase, except for the 3-month follow-up. So in terms of dose, we weren't overly prescriptive in giving them like one dose. We kind of counseled them on their options. Most people did between 18 to 35 milligrams of the whole mushroom blend. Or I should say the dosing is sort of based on the psilocybin content, but they did consume whole mushroom. And for those who were on an antidepressant, they could still participate, and that tends to have a little bit of a blunting effect. So those who were on SSRIs were able to take a bit of a higher dose. All right, so this was an uncontrolled study. So there means there was no placebo group. There was nothing to compare it to other than participants before they started and after they received treatment. So that's why it's part of being a feasibility kind of early stage clinical trial. We just don't have the means to do a control group. But we wanted to look at least on a comparison of what this would have costed on an individual basis versus doing it in groups. And so we'll show you some numbers on how that turned out in the end. And outcomes. So now we'll get into the results. First of all, as I said, a feasibility study is more interested in can we complete the trial? Do people show up? Do they drop out? Do they, are they satisfied? Do they feel safe? And on all those metrics, we got extremely positive results. There was zero severe adverse events. The adverse events that we did see were very minor temporary things that you expect in a psychedelic intervention. A couple people threw up, a few more people felt nauseous temporarily, some headaches, moments of a little disorientation, but nothing serious. And then we asked them, how satisfied they were with their experience overall. Nobody rated below a 4 out of 5, and most skewed toward a 5 out of 5. So we ended up with 4.8 on average of those who completed the study. So if I were a business looking for a Google review, I'd be very happy with how people felt about the study. So the primary outcome that we were interested in, it was depression. And so we used the Hamilton Depression Rating Scale, which gives you a score between 0 and 30, where above 23 is very severe depression. And at baseline, the middle score, close to the average, was around the cusp of 23. It was, I think, 22 in here. And so you can see after treatment one, the average goes down quite a bit. It goes even down further at the completion of treatment after treatment two. And then we did a 3-month follow-up again. And as is the case in most psychedelic research, there is a little bit of a rebound on average, but still remained incredibly positive. And so you can also notice here that the blue lines represent individuals' scores, and the red line is the average of all participants in the study. And so there are some outliers here, and just want to be transparent about that. Like this doesn't, it's not a miracle cure for everyone who participates, but the vast majority of people here saw a really significant improvement. And even these outliers, when I talked to them at their 3-month follow-up, they were incredibly grateful for the experience. They felt like they received a lot of benefit from it. And their depression scores being really high at the end, they related to just like really difficult life circumstances that they were going through. So it wasn't so much that the treatment failed them as life was just still really hard, and they were still kind of struggling a bit. So just to give that a little bit of context. So I won't go into a big, deep explanation of the statistics involved here, but just to say the comparison of their baseline score to their depression score at the end of treatment was really statistically positive, and the effect size reflects that it worked really well. And so we compared that also again at the follow-up period, and it was still highly significant and still indicated that it was really effective, even though it goes down just a tiny bit. Still really good results in terms of the statistical results of the analysis here. Now, we also collected some data using this measurement called the Promise 29 scales that looks at a bunch of different life factors, and it asks them a couple, like 2 or 3 questions about these 8 different subscales, including physical function, ability to function in social roles and activities, cognitive function, and there's a few more on the next screen I'll show you as well. And to my surprise, people improved on all 8 of the subscales. I'm not showing you depression because it was a little redundant. We did the Hamilton for that, which is more comprehensive. So I'm only showing you 7 on the screen, but they improved in all of them. And so I just wanted to give you the sort of the high level graphics here, where these are all positive improvements. Physical function goes up. You see a little bit of rebound in each case here after follow-up, but really good results here. And then here are the others: fatigue, anxiety, sleep disturbance, and pain interference. These are scores that you want to see go down, and they did go down on this screen. And the red line here, just by the way, represents it says it's 50, which the measure is calibrated so that 50 represents the average American. So you can see how in this population on both of them, people were below average, meaning they had more physical dysfunction, less cognitive function, and this intervention actually brought them closer to the normal American, which is pretty impressive. The least strong of these results was pain interference. You can see it's kind of the most mild curve, still some improvement, but that improvement didn't, from a statistical testing standpoint, didn't last during the follow-up period. So pain interference was no longer statistically significant with the follow-up period, but still some good improvement even at the completion of treatment. So that's just what that slide says there. So we also asked about quality of life and saw a statistically meaningful improvement there as well. So that's just a scale of 1 to 100. How do you rate your quality of life? We saw a meaningful improvement, which is really encouraging for someone struggling with poverty. That's a big deal to say that we kind of move the needle in improving their lives, even though this had nothing to do with changing their economic circumstances. So everyone, we also asked a series of questions just about, kind of safety and quality, and people felt it was really highly beneficial, low harm, and just felt generally really well held throughout the treatment. And you'll hear a little bit more from Olivia, who I'll hand it off to here in a minute to tell some more specific stories. But in terms of cost, this is how much the treatments would have costed just at market value based on what we decided to pay people and stuff, kind of middle of the road costs and whatnot. So doing it in groups resulted in a per cohort cost being around $11,500. Doing the same amount of treatment one-on-one, equivalent amount of time for the individual, would have come out to costing $26,800 or closer to $26,900. So some significant cost savings. That's a 2.3 times more efficient from a cost perspective doing it in groups, which is pretty significant when you're thinking about potential insurance coverage and payer perspectives on this, which is not to say that doing this therapy in groups is appropriate for everybody. There are other reasons why one-on-one might be more appropriate in certain circumstances, but it is noteworthy to point out that it can be really beneficial to do these things in groups, not just from an economic standpoint, but even from a therapeutic standpoint. But I'll let Olivia tell you a little bit more about that. So just to wrap things up, there were some limitations to the study. It's a small group. It is a feasibility study, which means it's kind of early stage. There's no control. Our group wasn't as diverse as we would like to see. And then doing research in the state program is an incredible opportunity to do something very unique. But there also are some limitations that, we couldn't design the experiment the way we would have if we were doing it as a traditional, like FDA approved clinical trial. And then we also recruited from people who are already interested in psychedelic therapy, which is not necessarily as generalizable as if we had just gone to like a community mental health place. So we would like to do kind of a bigger, better version of this study in the future, making sure we get rural and urban populations. We have a better representation of the general population in the future study. So in conclusion, for my part, before I hand it over to Olivia, is that this feasibility study demonstrated that a low-income population with depression can really benefit from psilocybin therapy done in a group. It was safe, it was well tolerated, and we saw really meaningful improvements in their lives. So thank you for indulging me in talking about this study, and I'm going to hand it back, or I'm going to hand it to Olivia now to talk a little bit more about the experiences that some of the participants had.
Thank you, Matthew. So for the last part of our presentation today, I'm just going to be sharing some quotes from the participants in the study. If you could go to the next slide, please. So during the screening visits, prior to starting the group part of the trial, almost everyone expressed hesitation at this being a group experience that they would be having. There was some fear of vulnerability, some potential for feeling some shame in whatever might come up for each of them. But by the end of it, everyone was so glad that this study was actually done in a group format. And that was a really beautiful thing to witness, from seeing the initial hesitancy in the one-on-one medical screening intake to the kind of nervousness at the beginning of the first preparation session with everyone, and then to see the camaraderie and friendship that developed by the final integration session at the end of the month that these people went through together. So the group therapy, we saw really increased trust, safety, and a sense of belonging for these people over time. After each of the psilocybin sessions, they were able to share their journeys with one another. And in this reflective group space, they had more profound insights than they would have had if they were just on their own in a one-on-one situation with a facilitator or therapist like Matthew and I. Another hallmark of any illness, especially mental illness, is the isolation that comes from being different than everyone around you, having reduced capacity in many ways. As Matthew showed with the Promise 29, these people not only had what we call depression, but they also had limited mobility, limited ability to handle social situations, pain, sleep disturbance, all of these things that become exponentially isolating over time. But by doing this in a group format, we reduced that isolation. We normalized these people's experiences. They helped normalize them for one another, that they were going through both outside of the study as well as inside of the study. And so they had breakthroughs on an emotional level, not just through the medicine, the psilocybin, but through connection with one another as well. Okay, we can go to the next slide. Great. And the last thing that I want to share are some looks into just how impactful this experience was for people. And it wasn't only impactful during the month that the study was taking place, or it wasn't only impactful on the days of the psilocybin administration sessions. But we see from the first quote, now that some time has passed and the afterglow is worn off, the journeys are still providing rich content for me to bring to my individual therapy sessions. 6 months later, I am still exploring the depths of what came up for me on those 2 Mondays. I imagine it will continue to stay with me for a very long time. I'm just super grateful to have been a part of this study. I felt an improvement to my depression almost immediately, and I am still learning from my experience. Immediately after the session, I noted a marked improvement in my depression. For the first time ever, I have been on something in the neighborhood of 10 antidepressants and have never experienced an obvious and marked improvement like this. I think that this so clearly speaks to how profound this intervention can be, how effective it is. And when people are provided a really safe, really thoroughly prepared container for this sort of experience, and when they have ongoing therapy and support in their lives, otherwise, the effects of just two small treatments can have months, if not years, of effect on people and improve so many other aspects of their lives. Often in medication trials, we hear about all of the horrible side effects of medications. They fix one problem, but then create 10 others. Whereas what we're seeing with psilocybin and other psychedelics is that we get side improvements. Not only does the depression get better, but so does the sleep, so does family relationships, so does one's ability to just show up in the world and work. We had wanted to have one participant come and actually speak to you today, but the business that he runs just took off after this study, and now he's too busy to be here. So, we might also be seeing this as a helpful component in people's walk out of a poverty cycle as well. It's really incredible to have been a part of this study, and I'm so happy to be sharing it with you all today. And I'm really excited to see what can come with more research in this model.
Thank you, Dr. Hicks and Dr. Hicks, for that research recap. So I am going to ask people to either unmute themselves and ask a question or drop a question in the chat if anyone has any.
I have a question.
Go for it, Nathan.
Wonderful. Nathan Wilt, KLCC. I came in a few minutes late, so forgive me if you addressed this early on. You mentioned, I think, up to 50 milligrams of SSRIs, or 50 milligrams of psilocybin for those who are on SSRIs. I guess it was my colloquial understanding that mixing SSRIs and psilocybin can cause serotonin storm or serotonin syndrome. Can you talk about, I guess, the risks of that or lack thereof?
Yeah, so there was previously that risk was believed or assumed to be a concern because they're both acting on the serotonin pathway. But what has been found is that in the case of SSRIs and SNRIs, serotonin norepinephrine reuptake inhibitors, is that risk just isn't there. And so there's been at least two clinical trials that have had people on SSRIs who also underwent psilocybin therapy, and this just didn't happen. The serotonin syndrome or serotonin shock, sometimes it's called, just didn't happen, and so it's been shown to be safe and still effective, but there is a bit of a blunting effect. So you need a little bit more psilocybin to reach the same level of psychedelic experience if you're on one of those. So that's where we allowed people to go up to the maximum allowable dose under the OPS rules, which is 50 milligrams if they were on an SSRI. Most participants we kept at that 35 milligram because that's helped us maintain the required ratio of facilitator to participants more in balance. I hope that answers your question.
Absolutely. Thank you.
Mhm.
Other questions?
Yeah, I have a question. This is Stephanie Domrat with KGW. I know one of the difficulties with being able to get solid research around psilocybin impacts for people is really being able to follow them like in the long term. So seeing these results and seeing, a little bit of a decline after 3 months, what does this tell you about, more longer term impacts and kind of like what this could mean for maybe whether patients should be getting, regular doses throughout a year or, just other types of timeline of treatments that would be effective long term?
Yeah, it's a good question. And we don't know exactly. I mean, there's been a few studies that had a longer follow-up period where people are still having statistically significant effects 6 months down the road. I'm not sure what the longest study shows yet. Obviously, like doing those kind of like really long-term studies are difficult. It's hard to keep participants engaged for that long and responding to surveys and whatnot. One of the other projects that Sherry Eckert Foundation is partnered with the Center for Psychedelic Economics or something like that at UC Berkeley is trying to do is look at longer term healthcare utilization data for people who have participated in psychedelic therapy and seeing does that change the way they utilize healthcare? Is there a cost savings? Do people do less psychotherapy or visit their primary care doctors any more or less after doing psilocybin therapy? And it remains to be seen. Like I said, that's difficult research to do because you need access to a lot of healthcare records and data and stuff. But we're optimistic because anecdotally it seems to be the case, but we don't have really robust evidence for it yet, but that is an emphasis that I know a number of researchers, including myself, are looking at to help build the case for something like insurance coverage, where we're saving taxpayer and insurance payer money in the long run by these treatments that are hopefully more effective than some of the standards of care that we're currently paying for.
And if I could just add, the Open Psychedelic Evaluation Nexus, which is also based out of OHSU, is doing a 12-month study with participants who go through the program. They launched at the end of last year, so they're starting to see some of that data, but it'll be a few more months before we'll start to see data at the scale that we can really see what's the impact over a 12-month period. But certainly when they go to release that, we'll also be helping to amplify what they're finding in their studies.
Sarah Honeycutt, you have a question?
Yes, thank you. I'm curious, you said you gave the pricing of what it costs between individuals and running a group program to do this study. And I'm curious if you are aware of what it would cost to run something like this through an FDA trial, and like how much more economical is it to run through this state regulated program?
Yeah, it's a good question, and I haven't, I haven't run a budget exactly that would compare that to answer you very precisely, but I can say generally that doing things that way is it's just generally more expensive. There's a lot more bureaucratic work to be done and more layers of approvals. Now, I also want to say, to that we did do a lot of the same things, like right the institutional review board is a big hurdle to like all these institutional checks. It was still registered on clinicaltrials.gov, and I had to do a lot of background research on and communicate with the DEA, the Drug Enforcement Agency, and who ultimately agreed with my interpretation that operating within Oregon Psilocybin Services does not make me liable to DEA rules as a DEA prescriber, because I do ketamine work, which requires a DEA license. But because Oregon Psilocybin Services rules say that I'm not administering psilocybin when I'm facilitating, in fact, rules prohibit me from even handing it to a client, that it was basically an observational study. So anyway, it gets very technical, like following all the rules. I could kill you with details right now if you really let me ramble for too long about it. But it's a different model in that a more FDA medical approach does carry a lot more liability and cost to get all the approvals and to approve at more levels versus doing it here in the Oregon model was a little bit quicker and easier. So yeah, that's my general answer as best as I can summarize it for you.
And we did a Healing Advocacy Fund did just kind of an informal survey of people who have run clinical trials. And what we heard is it generally can run from anywhere around starting at 15,000 per patient up to 100,000 with per patient, with kind of the middle being around like 30,000. We often hear of clinical trials of small numbers of people being in the multi-millions. But that's the range compared to the numbers that Matthew provided earlier. And again, that 15,000 is really for one patient to go through the clinical trial. But they usually run significantly more than what is able to be run within the Oregon program.
And the
What
numbers
was
I
the
showed you on the screen, by the way, were just sort of the costs directly for the intervention itself, not the research costs. So typically you have, to pay a statistician, and I didn't really talk about like my salary that, took that had to like do all the forms and organize everything, the way I did. So paying a researcher to do all of that is often a big, cost of doing research, obviously. Mhm.
other?
Can you tell us what was the cost at the end? And also, the sessions were all done at Intertrack, is that right?
No, Intertrack wasn't involved at all. It was Chariot was the service center we used. And I'm sorry, what was the first part of your question?
So what was the total funding for the?
Yeah, so there were, I guess you could say, three sources of funding. One is that my salary was funded through a federal grant. So that if it were included in this budget would be the single largest item, would be just have been my salary. But then the Sherry Eckert Foundation gave us a $30,000 grant, so that covered the cost of the participants to go through the therapy and to pay, Olivia as a facilitator, and to, yeah, pay some of the fees. We also paid the participants a $200 incentive for filling out all the extra forms and whatnot. So that 30,000 is the short answer, but not including the cost of funding me as a researcher, and also just a deep amount of gratitude to the National University of Natural Medicine, NUNM, who did not receive any funding. So my mentors didn't get paid for this. The IRB did not get paid for it. So they kind of donated their research services to make this possible as well. So it's the amount we spent on this study is not easily reproducible. It required a lot of generosity from a lot of people, including the mushrooms which were donated. So that was several $1,000s worth of mushrooms that were donated as well.
Yeah. Hey, everybody. Just real briefly, thanks, Elizabeth. Great to see you. Good to see a lot of friends here. But I would love to offer a small amount of color commentary on those last two questions, which I loved. modeling that we did, or rather research, which is not perfect because it's hard to compare apples to apples here. But to Heidi and Matthew's point, just the numbers that we have come up with is we got Matthew at a bargain basement price. You know, he had a fellowship, he donated a lot of time. Olivia as well. The university was supportive. We worked with Tori and Satori Farms and got the mushrooms donated. But the grand total cost out the door was $30,000. I linked to that in the chat, a write-up that the university did for comparable projects in terms of what was actually published about the costs for similar trials of similar number of people. They had an estimated range of $7 to $20 million. So again, hard to compare apples to apples exactly, but that would put an average participant cost of between $30,000 to $130,000 for more complex patients. So I don't know. I think Oregon does cool things, including making this research much more economical, quicker. And then the study, which I've been calling either the Big Kahuna study or ORCID, the actual name of the research that Matthew alluded to. I'm putting it in the chat here. This is Oregon research on care and health insurance costs after psychedelic services delivery. So this is working with hopefully Matthew as well, but some of the preeminent researchers in the United States generally, but specifically on healthcare and some of the healthcare economists as well. And so this is a partnership between a lot of folks on this call, including UC Berkeley and their economics for psychedelics center, to really look at in a large sample size over multiple years the impact on healthcare costs. And I'm not a researcher, so a lot of those calls feel like I'm back in Japanese school. I just don't know what is going on, and we'll see what the results are. But there are a lot of analogs that show that there are real cost savings, in which case you have me saying probably inevitability that we see that this leads to serious cost savings in some way, which is why we are bullish on healthcare insurance arrival. And we're just trying to get it here quicker because some people have said that we have like a mental health crisis, maybe, and like an addiction crisis. So it could be helpful to have the most effective therapies covered. Okay, those are the two questions I wanted just to weigh in.
We have to jump. A lot of the speakers have to leave. I would like to ask Olivia to stay. KGW wants to ask you a question with just your face on the screen, so I'm going to unspotlight people. But thank you so much, everybody, for coming. Really appreciate your attention to this. I'm available for follow-up if you need anything.
Thank you all.
I'm going to unspotlight Matthew and Nathan here. And myself.
You don't want my face. Olivia. Olivia is who the people want.
Okay, KGW, go for it.
Thank you. This is Stephanie with KGW. Olivia, I was just wondering if you could speak again to what you said earlier about like side effects with medications and that you see side improvements with psilocybin. So can you kind of repeat that and just talk about that again for me?
Absolutely. So, in the 3 years that I've been a psilocybin facilitator licensed here in Oregon, something that I have seen again and again are the side benefits that come from psilocybin use. As Matthew highlighted in the study, there were some mild adverse events. On the day of sessions, people did feel some nausea. There was the occasional vomiting or a sense of dysphoria, disorientation. But in the long run, in the weeks and months after these sessions, people experience benefits that are not just related to their mood and their perceived sense of depression. They can feel improved social function or ability to communicate and be a part of their family. They can feel an improvement in pain, an improvement in their sleep quality. There are just so many other benefits to this. Sometimes people feel the need to use alcohol or cannabis less, even if they don't have an outright addiction to those things, versus with, many traditional psychiatric medications, weight gain can be a side effect. of them. Decreased sexual function is another side effect of these medications. Suicidal ideation is a side effect of some of these antidepressant medications. And it's just a really stark contrast between the two. And often people can be on these things for years and years and years, and they're really just a band-aid, helping them cope, which is very necessary in some cases. You know, I do work with them and prescribe them in my own practice, but I don't see them being the end-all be-all and the solution to this crisis that we're facing, versus the insight and community building and benefit that things like psilocybin, especially when done in a group in a relational way, can bring to people.
Thank you. Can you speak to why, I guess there was a note in there about on one of your slides that was about access for people who were previously incarcerated. Is that something that you guys are looking at moving forward? I don't know if that was a Nathan question, but I had more interest in that too. Thank you, Olivia.
Thank you.
Nate, do you want to talk about that?
Absolutely, I do. Love that question. Thanks, y'all. Let's see. I'm gonna spotlight myself. Is it okay if I spotlight everybody who's still here? Or what would you prefer in terms of video? Oh, Dr. Olivia. Adios. Great to see you. Thank you. All right. So yeah, let me share briefly, and I'm going to put this in the chat as well, in case you all want to reference. But this is a project that we now have secured $400,000 for, and climbing, to serve previously incarcerated folks and folks that we describe like the language that's being used in this world is justice impacted. So whether these are individuals who have served time in prison or in jail or have been through a traumatic arrest or prosecution, or a family member of someone who has, this is intended to serve them through Oregon's legal psychedelic or psilocybin services and healthcare model, for whatever reason they might have. And so we are actively serving those individuals from around Oregon and the United States right now through the Inward Eye Fund, which I've put in the chat, and also currently accepting applications for this as well. And there are a duo of research overlays to this project. I'm not ready to talk about them just yet, but the headline is that we will be looking into the impact that receiving these services have on folks who have whatever sort of outcomes may occur from serving time in prison or being just as impacted, whether that's PTSD or issues related to on-process trauma, as we are understanding that's a significant driver of addiction and other behaviors that are hard to treat. So that research is coming soon, and for just folks who may see this, or just anybody who knows someone who might benefit, we're currently accepting applications for this fund. And then there's another fund as well that I'll just briefly mention, and this is to serve individuals who serve others. So this is community leaders. So we're actively building groups of nonprofit leaders in Portland and Oregon and the Northwest who either are approaching burnout, or this is intended to serve them so they don't approach burnout. And it also includes interfaith leaders, so spiritual faith and religious leaders will be coming and are beginning to apply and get kind of locked into retreats throughout the year and going into next year. So whether this is nonprofit leaders, interfaith leaders, or environmental leaders as our focus groups, the goal is to kind of give folks that support others support. And it's based on a theory of change of continuing to or trying to support people who do so much that they may not have the time to kind of resource themselves, or even realize whether they're at burnout or not. So this is a well understood practice, but it is new in the form of doing it with psychedelics in a legal fashion. So there will be a research overlay on this as well, looking at the impact on those individuals and the organizations they run. Does working with this medicine impact the businesses, organizations, and nonprofits or movements that they lead in terms of impacted quality of life for their employees or their staff? Is there a change to individuals and their philanthropic giving for folks who may go through the Community Leaders Resilience Fund who have large philanthropic potential? So those are the things we'll be looking at through that research study. And again, we're actively serving these folks, and people can apply for it today. Okay, not that you asked about it, but there you go.
Thank you.
My pleasure. All right, it's 11:08. Do folks have any burning questions? You can ask any question. I don't know if I can answer it, but I'm down to hear anything people might have. And really, you should probably talk to the researcher, Dr. Matthew, for specifics around the main event, the study. I'm going to give it maybe like 2 minutes. And if there are no questions, maybe we can pop. All right. And Matthew, if you have anything to share too, please feel free to. All right, as my Mount Tabor Middle School teacher would say, last chance summer dance. I think it was like a Z100s slogan back in the day. Last chance summer dance. Any other questions before we jump? You put it in the chat. You can unmute yourself. Well, I got a question. Nathan Wilk, KPTV, Annie, Travis, KGW. Would you all like to have an interview or a follow-up conversation with Dr. Matthew Hicks or Olivia here, or anybody else that spoke? No need to unmute or put in the chat if you would not like to, but just want to extend the offer. Should it be helpful? 5, 4, 3, 2, 1. Thanks, y'all. Thanks for tuning in. Thanks for being part of the most important part, being alive, being our storytellers, our journalists, Fourth Estate. Thanks for tuning in. Matthew, any parting words before we jet?
No, not really. Just thank you all for being here, and yeah, thanks for organizing.
All right, y'all. Thanks, y'all. Bye.